Welcome to Evidence-Based Cardiology Talks. This is where we delve into the latest research shaping contemporary cardiology.
That's right.
Today, we're doing a deep dive into something really fundamental, the brand new 2024 ESC Guidelines for managing elevated blood pressure and, well, hypertension.
Yeah, these are incredibly important. They represent the official stance of the European Society of Cardiology, based on a really thorough look at all the current science and medical knowledge.
Absolutely essential reading, I think, for any cardiologist or healthcare professional dealing with hypertension day to day.
Definitely, it's the official position, carefully reviewed.
Now, look, these guidelines are pretty extensive, as you'd expect. We want to pull out the key clinical takeaways, the practical nuggets that you can actually use to guide your practice precisely. And just to mention, this discussion is supervised by Dr. Caroli, drcaroli.com, ensuring we're grounded in expert insight.
Good point. And to keep things clear, we're basically going to follow the structure of the guidelines themselves, section by section.
Sounds like a plan. So let's jump right in with Section 5, which makes sense, starts with the absolute basics, measuring blood pressure.
It really is the foundation, isn't it? Get this wrong, and everything else is kind of built on shaky ground.
So what's the big emphasis here in the new guidelines?
Well, they really hammer home the need to use clinically validated devices. They even point you towards websites like stridebp.org and validateebp.org.
Oh, right, to check if a specific monitor is actually approved.
Exactly. And this is pretty striking. They note that only about 6%, a really small fraction of the oscillometric devices out there, have actually been properly validated against current standards.
Wow, 6%. That's actually quite low. I mean, a lot of readings might not be accurate.
That's the potential implication, yes. It could lead to misdiagnosis, or, not treating someone who needs it, or over-treating someone who doesn't. So checking validation is key.
Definitely something for everyone listening to perhaps check in their own clinics. They mentioned a universal standard too, a Mishiso?
Yeah, that's likely the standard that, going forward, will ensure better reliability across different devices as more manufacturers adopt it.
Okay. And the methods themselves. Auscultatory, the old stethoscope method versus oscillometric, the automated ones.
Well, for most routine measurements, good quality automated oscillometric devices are fine, especially the ones that take multiple readings and average them out. But manual auscultation is still preferred for patients with atrial fibrillation.
Ah, because the automated ones can struggle with the irregular rhythm.
Precisely. Their accuracy hasn't been consistently validated in AFib. So stick to manual auscultation there.
Got it. And the idea of multiple readings and averaging still best practice?
Oh, absolutely. Essential to smooth out variability and get a truer picture. The guidelines also put quite a bit of focus on automated office blood pressure, or AOBP.
Okay, AOBP. Can you just quickly recap what that involves?
Sure, it's using an automated device in the clinic, but usually the patient is resting quietly, often alone in a room. The machine takes several readings, maybe 3 to 6, a minute apart, and averages them.
And the benefit is?
Well, evidence suggests AOBP readings correlate better with 24-hour ambulatory monitoring ABPM than, say, a one-off manual reading. And it helps reduce that white coat effect significantly.
Right, makes sense. More objective. And cuff size, technique still critical.
Non-negotiable. Correct cuff size, proper patient positioning, arm support. All still fundamentally important. And they also remind us to check for postural hypotension.
Orthostatic hypotension, yeah. When should we do that?
Definitely at the first visit. And anytime a patient reports symptoms like dizziness when they stand up, you're looking for that drop of 20 systolic or 10 diastolic within 3 minutes of stand.
Okay. Now, what about outside the office? Home blood pressure measurement, HBPM. Hugely important now, isn't it?
Absolutely vital for long-term management. And the guidelines get very practical here. Use a validated device, of course. Quiet room, rest for 5 minutes, back and arm supported.
And the actual measurement schedule?
2 readings, about 1 or 2 minutes apart. Do this twice a day, morning and evening.
Yeah.
And keep it up for at least 3 days, but ideally a full 7 days before the clinic visit. Then you average all those readings.
And the threshold for hypertension based on those home readings?
Still 130/585 millihg.
Okay. And how does ambulatory blood pressure monitoring, ABPM, fit in? The 24-hour monitor?
ABPM gives you information you just can't get otherwise. Critically, it captures nighttime blood pressure, which is a very strong predictor of risk. It can also pick up masked hypertension or white coat hypertension or transient drops or spikes.
So they're complementary tools, HBPM and ABPM.
Exactly. They complement each other. One isn't necessarily better. They just provide different valuable pieces of the puzzle.
And briefly, any specific points about measuring BP in pregnancy?
Yeah, it's tricky. As we mentioned, validation of automated devices is limited in pregnancy. They can sometimes read falsely high. So auscultation really remains the standard there. They also reference the Chianti trial showing benefit for treating mild hypertension in pregnancy to a target below 120/90.
Good summary. Okay, let's shift gears to section 6. Cardiovascular disease risk assessment. This is where we put the BP number into context, right?
Precisely. It's not just about the number. Measured BP needs to be combined with an estimate of the patient's overall 10-year cardiovascular risk.
How do we estimate that risk?
For people aged 40 and over, without those very high-risk conditions we mentioned, the guidelines recommend using the SCORE-2 and SCORE-2-OP risk prediction models.
Okay, the SCORE-2 models. They use factors like age, cholesterol, smoking.
Exactly. Age, sex, smoking status, systolic BP, and non-HDL cholesterol. They give you that 10-year risk percentage. SCORE-2-OP is for older people, factoring in competing risks.
But what if someone already has confirmed hypertension? Do we still need to calculate the SCORE-2?
Good point. Generally, no. If hypertension is confirmed consistently, 14 and 90 millilib/Hg, or meeting home ambulatory criteria, the recommendation is usually to initiate BP-lowering treatment without needing further formal risk stratification with SCORE-2. The diagnosis itself implies sufficient risk.
Okay, that simplifies things. So SCORE-2 is more for guiding decisions in people with elevated BP maybe, but not full-blown hypertension yet.
That's a key application, yes, or for understanding the overall risk context even in treated patients. The guidelines also list conditions that automatically put someone with elevated BP into a higher risk category.
Like what?
Things like diabetes, familial hypercholesterolemia, any established cardiovascular disease, moderate or severe chronic kidney disease, or evidence of hypertension-mediated organ damage, HMOD.
HMOD being things like LVH on an echo or protein in the urine.
Exactly. Left ventricular hypertrophy, microalbuminuria, advanced retinopathy, increased arterial stiffness signs, the high pressures already affecting organs. There's an exception noted for younger type 2 diabetes patients under 60, where a SCORE-2 diabetes might be used.
Interesting. Now, the guidelines also talk about non-traditional risk modifiers. Some are specific to women, which feels like an important area of focus.
Yes, definitely. This is getting more recognition. For women, a history of hypertensive disorders of pregnancy, like gestational hypertension or preeclampsia, is a key one. Also gestational diabetes, preterm delivery, recurrent miscarriage, stillbirth.
And how do these factors influence risk assessment?
They can essentially bump a woman up into a higher risk category. If her calculated SCORE-2 risk is borderline, say between 5% and 10%, having one of these histories might justify considering her higher risk and potentially intervening earlier.
That's really significant for long-term women's health. Are there non-traditional factors common to both men and women?
Yes, several are mentioned. Things like high-risk ethnicity, like South Asian descent, a strong family history of premature heart disease, certain autoimmune diseases like lupus or rheumatoid arthritis, severe mental illness, HIV.
Do these factors significantly change the risk scores?
Well, the guidelines are a bit cautious here. They note that while these factors are important considerations, it's not always clear how much they consistently improve risk prediction beyond the standard SCORE-2 factors. So consider them, but the core risk assessment still leans heavily on SCORE-2.
Okay. And if there's still uncertainty after all that, any tiebreaker tests?
Yes, they mention a few risk decision tests, things like a coronary artery calcium score, looking for plaque in the carotid or femoral arteries with ultrasound, measuring arterial stiffness with pulse wave velocity, or checking biomarkers like high-sensitivity troponin or NT-proBNP. These might help in borderline cases.
So it's a layered approach. SCORE-2, then non-traditional factors, then maybe these extra tests if needed, all aimed at guiding treatment decisions, particularly for elevated BP.
Exactly. It's about tailoring the intensity of prevention based on that comprehensive risk picture.
Right, which brings us neatly to Section 8. Preventing and treating elevated blood pressure and hypertension. Let's start with the non-drug approach's lifestyle. Still the cornerstone.
Absolutely. Foundational for everyone, regardless of BP level. The guidelines really reiterate this. Sodium restriction is key, aiming for around 2 grams of sodium per day.
Which is about 5 grams of salt, right? That's quite a reduction for many people.
It is challenging. They mention the DECIDE SALT trial supporting this, but also acknowledge that maybe aiming for 2 4-gram sodium initially might be more realistic for some. A big part is avoiding processed foods, where most of the salt hides.
Good practical advice. What about exercise?
The recommendation is 150 minutes a week of moderate aerobic activity, like brisk walking, or 75 minutes of vigorous activity, like jogging. Spread it out over the week.
And resistance training.
Yes, that's important too. Low or moderate intensity resistance training, 2 or 3 times a week. That could be weights, resistance bands, or even isometric stuff like hand grip exercises, planks, wall
It's
sets.
interesting they mentioned isometric specifically.
Yeah, there's growing evidence for their BP lowering effect. But there's a caution. Avoid very high-intensity exercise if someone's BP is really uncontrolled at rest, like over 2001-10.
Okay. Weight and diet.
Aim for a healthy BMI,
Yeah.
20-25, and keep waist circumference down less than 94 centimeters for men, 80 centimeters for women. Diet-wise, they recommend patterns like the Mediterranean or DAS diets. Lots of fruits, veggies, whole grains, lean protein.
Alcohol.
Limit it. Less than 100 grams of pure alcohol per week. Though they do add that avoiding it completely is probably best for overall health. And obviously stop smoking a class I recommendation.
Any other lifestyle points?
Yes, restrict free sugars, especially sugary drinks, to less than 10% of energy intake. And consider increasing potassium intake through diet or potassium-enriched salt for those with hypertension who eat a lot of sodium, provided they don't have advanced kidney disease.
That's a comprehensive list. Okay, let's talk drugs, pharmacological interventions. What's the main goal?
The bottom line is preventing bad cardiovascular outcomes,
Yeah.
heart attacks, strokes, heart failure, kidney disease. And the relative risk reduction you get from lowering BP seems pretty consistent, regardless of where you started from, BP-wise.
So the lower is better idea still holds.
Generally, yes. Lower the better, within reason, is the mantra, meaning get it down to target levels as long as the patient tolerates it.
And how should we start drug therapy? This seems to be a key change.
It is. For most patients diagnosed with hypertension, the recommendation now is to start with low-dose combination therapy right from the beginning.
2 drugs at low dose rather than 1 drug maxed out first.
Exactly. The rationale is you get better BP control faster, often with fewer side effects than using a high dose of a single agent, and this seems to improve adherence.
When would monotherapy still be appropriate?
If there's a very specific reason to use one particular drug class, like a beta blocker after an MI, or maybe in very frail or very old patients, where you want to be extra cautious starting low and slow.
And which drug classes are the main players?
The big 5 are still the core: ACE inhibitors, ARBs, RAS blockers, beta blockers, calcium channel blockers, CCBs, and diuretics, specifically thiazides or thiazide-like ones like indapamide or chlorthalidone. All class I, level A evidence.
What about beta blockers? Their role seems more defined now.
Yeah, they're recommended mainly when there's a compelling indication alongside the hypertension. Things like angina, post-heart attack status, heart failure with reduced ejection fraction, or if you need rate control for AFib. In those cases, you'd combine them with one of the other classes.
Makes sense. Does it matter when patients take their pills? Morning or evening?
The guidelines basically say take them whenever is most convenient for the patient to help them stick to the routine. Adherence is key.
And to help adherence, they recommend.
Single pill combinations whenever possible. If someone is on 2 or 3 drugs, getting them 1 pill improves adherence significantly.
So if 2 drugs aren't enough.
The next step is usually a 3-drug combo, typically a RAS blocker, a CCB, and a thiazide-like diuretic. Again, ideally in a single pill, if available.
And which drugs have the best evidence for reducing actual events, not just lowering BP?
The guidelines highlight that ACE inhibitors, ARBs, dihydropyridine CCBs like amlodipine, and the thiazides like diuretics have shown the most consistent benefit in reducing cardiovascular events in major trials.
Okay, let's get to the targets. Section 8.5. What numbers should we be aiming for?
First goal for everyone, get the BP below 14E90. That's the initial hurdle.
But ideally lower.
Yes. For most patients, the target should be 8, 30, 80 millimillimeter ejection if tolerated.
And is there an even lower systolic target suggested?
There is. For cardiovascular risk reduction, they recommend targeting a systolic BP between 120 and 129 milliliter G in most adults. Again, if treatment is well tolerated, this gets a strong class I, level A recommendation.
120, 129 systolic. That's quite specific. What about diastolic?
They suggest considering a diastolic target of 80 millimilli G for all hypertensive patients.
What if patients just don't tolerate getting down to that 120, 129 range?
Yeah.
Side effects like dizziness.
Then you invoke the LARA principle, as low as reasonably achievable. You lower it as much as possible without causing problematic side effects.
And for the very old or frail, are the targets different?
Yes, you need to be more cautious. Consider less stringent targets, maybe systolic 130 to 139 mmHg, if those lower targets aren't tolerated well. Individualize.
What if systolic is on target, say 125, but diastolic is still 85?
Good question. They say you may consider intensifying treatment specifically to get the diastolic down into the 70 to 79 mmHg range in that situation.
Okay, nuanced targets there. Before we hit specific populations, just a quick mention of Section 7. Secondary hypertension, when should we suspect it?
Screen if the clinical picture suggests resistant hypertension, very young onset, specific signs or symptoms. But interestingly, they now suggest considering screening for primary aldosteronism, checking renin and aldosterone, in all adults with confirmed hypertension.
Wow, in all patients, that's a potential shift.
It is. It reflects the growing recognition that primary aldosteronism might be more common than previously thought. They also list other causes like renal artery stenosis, sleep apnea, pheochromocytoma, with the relevant tests.
Okay, Section 9. Specific populations, young adults first.
Key thing here is using out-of-office BP, home or ambulatory, to confirm the diagnosis, because the white coat effect is more common. The treatment threshold is generally 14E90 unless they have other high-risk features. Assessing for HMOD can help refine decisions.
Pregnancy, we touched on measurement. What about treatment?
Classify the type: pre-existing gestational preeclampsia, low-dose aspirin for those at risk of preeclampsia. Treat if confirmed BP is E14E90. The target is generally 1480-80-90 mmHg. Avoid going much lower, like 120, 129 systolic, for now, pending more evidence.
Very old or frail patients.
Individualize completely. Think about comorbidities, function, lifespan. Less strict targets, maybe 130, 139 systolic, if lower isn't tolerated. Consider long-acting CCBs or RES inhibitors first. And importantly, review meds regularly and consider deprescribing if frailty increases or BP drops.
Diabetes.
Target 130/80 is recommended. Consider an ACE inhibitor or ARB first line, especially if there's kidney involvement. They acknowledge the J-curve debate at very low BPs in some studies, but stress the overall benefit of lowering BP to target.
And chronic kidney disease, CKD.
Lifestyle plus meds if BP is over 20/80. Target systolic 120, 129 if eGFR is above 30 and is tolerated. Below eGFR 30, it's more individualized.
We've covered a huge amount of ground. Let's wrap up with Section 11, patient-centered care. This feels increasingly important.
It's fundamental. The guidelines stress having an informed discussion with the patient about their specific risk and the benefits of treatment, tailored to them.
Using things like motivational interviewing?
Exactly. To boost adherence. Physician-patient web communication can also help, especially with home monitoring.
And home monitoring itself is key for engagement.
Yes, home BP measurement with self-monitoring empowers patients, improves control, and helps adherence. It's strongly recommended.
What about team-based care?
Also recommended, multidisciplinary approaches, task shifting where appropriate using nurses, pharmacists can improve overall BP control rates.
And the elephant in the room, medication adherence.
Crucial. Assess it routinely but in a non-blaming way. Non-adherence is a massive reason for uncontrolled BP. And again, single pill combinations really help with persistence.
Okay, fantastic overview. So if we had to boil it down, what are the absolute key takeaways from these 2024 ESC guidelines for everyone listening?
I'd say 1. Prioritize accurate BP measurement with validated devices. 2. Assess comprehensive CVD risk using SCORE 2 and non-traditional factors. 3. Embrace upfront low-dose combination therapy for most patients. 4. Aim for BP A180 80 and ideally systolic 120-129 if tolerated but individualized, especially in older frail patients. 5. Really focus on patient-centered care and boosting adherence.
Excellent summary. These guidelines really provide a robust, evidence-based framework for managing hypertension across the board. Thanks so much for joining us today for this detailed look at the new hypertension guidelines.